Yeah, sure.
Okay. So we are live now. Good evening and welcome to one and all. I'm Srevshi, the assigned moderator from Planet. Planet is India's most trusted and widely used digital platform with multiple enriching services for doctors. Planet is very proud to be a part as a digital partner for this event organized by Oncology Integrated Society. And the topic of today's session is role of radiotherapy in non-small cell lung cancer. So let's begin today's session, for which I would like to invite Dr. Deepti ma'am to take over. Over to you, ma'am.
Yes, hello, good evening, and welcome all the participants. Yes, it is a proud privilege to host this Oncology Integrated Society meeting webinar, the 26th one. And today we have eminent chairpersons and speakers from the special Arbindo Medical College, Indore, from where Dr. has taken his own his education of radiation oncology. And so a bit about the topic. Lung cancer is the most common type of cancer. People addicted to smoking are at the highest risk of developing this cancer. A man will develop lung cancer in his lifetime. It is about 1 in 16, and that for women is 1 in 17. The incidence rate in males was the highest in Kerala and Mizoram, while that for women it was highest in Manipur and Mizoram. So Mizoram is common. 90% of the lung cancers are due to cigarette smoking. Other causes are chemicals like radon and asbestos. The risk of lung cancer increases with age. An estimated of over 53% of people are diagnosed with 70 years or older, and an estimate of 83% are diagnosed with people aged 65 and older. Men are most likely to be diagnosed with NSCLC, non-small cell lung cancer, between the ages 80 and 84. NSCLC is less aggressive and SCLC is more aggressive with a poor prognosis. While NSCLC is most common in women found between the ages 75 to 79. The death rates for men with lung cancer dropped 5% each year due to the awareness campaign about stopping tobacco, smoking, and also because of the modern methods in the diagnosis and treatment. So, hardly 10% are of squamous cell lung cancers. So, we have come together to evolve and to find out the updates for the radiotherapy role in non-small cell lung cancer to upgrade our knowledge and to improve the survival rates in different institutions. So the 5-year survival rate in US is 33%, and that is for women, and for men it is hardly 23% in US. What about India? So we have to develop ourselves, we have to develop our knowledge, diagnosis, and treatment. For that, we have eminent personalities and dignitaries with us. So I would call Dr. Chaturvedi, who is the proud owner of Dr. Chaturvedi Cancer Hospital, who has had many trainings abroad in Sloan Kettering Hospital, Manchester, Japan, Kyoto, and Finland and Germany, has been observer in many abroad international institutes, and has been co-guide to many theses in medicine and pathology departments of BRD Medical College, Gorakhpur, and has many awards and publications to his credit. He has also been past president UPARI, of Uttar Pradesh, India. So over to you, Dr. A.K. Chaturvedi. Kindly introduce Dr. Virendra Bhandari, who is the chairperson of the event.
Thank you, Dr. Dixit. Somebody is ringing up. Welcome, Dr. Bhandari. Dr. Bhandari, as you know, is a renowned radiation oncologist. He passed out from MGM Medical College, MI Hospital, Indore, and he did he worked as senior registrar at TMH, Mumbai, and then consultant oncologist at Aurangabad, and treated all type of solid and hematological malignancies. He has got training abroad. He trained in brachytherapy, hyperthermia, IGRT, IMRT, SRT, SBRT, and whatnot at Christie Hospital, Manchester, UK, and DD Head Hospital, Rotterdam, Netherlands, Henry Ford Hospital, Detroit, 21st Century Oncology Clinic, Jacksonville, USA, and Humanitas Hospital, Milan, Italy. So many places he has taken experience. Presently, he is working as professor in radiation oncology at Sri Arbindo Medical College and PG Institute, Indore. He has got 19 years of teaching experience in medical college. He has 97 publications in various national and international index journal with 345 citations on Google Scholar to his credit. He is also editor-in-chief of Indian Journal of Cancer Education and Research, which is indexed in Indus Copernicus, and reviewer for many journals. So, Dr. Bhandari, with a lot of vast experience, now I welcome you to proceed further and invite our speaker. Dr. Bhandari, please.
Dr. Chaturvedi, please
Thank you, Dr.
lift your body a bit. You are very low.
Okay. Yeah.
ऐसे ही बहुत सुंदर है, कोई दिक्कत नहीं है, आवाज आती है, देश जानता है उनको.
Thank you so much,
Thank you,
Doctor.
Dr. Chaturvedi, for a nice and small introduction. Thank you, thank you. We are talking today lung cancer, especially non-small cell lung cancer, and that too role of radiotherapy in non-small cell lung cancer. And we have Dr. Ashar Iqbal Lodi with us, who is assistant professor in radiation oncology at Arbindo Medical College, Indore. He also has more than 11 publications to his credit and has presented many posters and oral presentations in various conferences. He will be presenting non-small cell lung cancer. And cancer is the most commonly diagnosed cancer and biggest cause of cancer mortality worldwide. And non-small cell is most of the cases. It plays a very important role in its management and is used once in over half of the patients in both curative settings. With the evolution of radiotherapy cancer that has underpinned improvements in radiotherapy technology, vast improvement in radiotherapy technology has come up that has improved the role of radiotherapy also. These improvements have facilitated geometric individualization, increasingly accurate treatment, and now offer the ability to deliver truly individualized radiotherapy. Radiotherapy in non-small lung cancer is required in very early stages, also in locally advanced as well as metastatic settings. And use of four-dimensional CT is in which the respiratory motion of the tumor is visualized as facilitated small margins individualized the patient's breathing cycle. This motion adoption reduces the risk of the geographical miss in the lung cancer, and also that has reduced the risk of radiation in pneumonitis, as well as improved the results and survival of most of the patients. Also, cone beam CT has replaced two-dimensional magnetic portal imaging that provides more accurate setup. Dr. Ashar will be talking in details on these advances, mostly radiotherapy. And over to you, Dr. Ashar.
Good evening, everyone. Thank you so much for the introduction, sir. Thank you.
Excuse me for
Uh,
the question. Yes, I'm just asking the Clarinet people. Just you write in the delegate link to put
Yes,
the
ma'am.
to put the email so that we can give them certificates.
Okay, fine, fine. Sure, ma'am. Sure.
You just give the write there in the chat box.
Okay, ma'am.
Okay, thank you.
Yeah, good evening, everyone. Thank you, Dr. A.K. Chaturvedi sir and Dr. Deepti Chaturvedi ma'am, for this wonderful opportunity to talk on this topic of non-small cell lung cancer, rather vast topic, but we'll be discussing just the radiotherapy aspect of it. And I have tried to keep it short, but it is a very vast topic. Let's begin. Is my presentation visible to
Yes,
everyone?
sir. Yes, sir.
Yeah.
Please make it full screen, sir.
Yeah, sure.
Yes, sir. Perfect.
Yeah. So we'll not be discussing any pathological aspects or risk factors or anything we are quite aware of. Our talk will be just concentrated on the radiotherapy aspect of lung cancer. So beginning with the first of all, the primary stage of the disease, that the T1 stage, which is less than 3 centimeter of the disease, is surrounded by lung or visceral parenchyma, not involving the main bronchi. And whereas the T1A, T1B, and T1C stages are less than 1 centimeter, 1 to 2 centimeter, and 2 to 3 centimeter disease. Whereas T2 disease is 3 to 5 centimeter disease with involvement of the main bronchi without the carina. Or then invasion of the visceral pleura. T2A being 3 to 4 centimeters and T2B being 4 to 5 centimeters. And T3 disease involving the chest wall, pericardium, phrenic nerve, or 5 to 7 centimeter greatest dimension, and T4 involving the surrounding structures. When the nodal stage we talk about, nodal stage is ipsilateral peribronchial hilar nodes or intrapulmonary node is N1 disease, and N2 is ipsilateral mediastinal subcarinal nodes. And when the contralateral mediastinal hilar nodes or ipsilateral or contralateral scalene or supraclavian nodes are involved, it is considered as N3 disease. M1 disease is the distant metastasis, obviously. In the contralateral lung is M1A, M1B is single extrathoracic metastasis, and M1C is multiple extrathoracic metastasis, one or more organs. So talking about the clinical stage, basically the N0 disease with the T1 or T2 disease comes under the category of early lung cancer, whereas the T3 disease onwards and with nodal positivity, it is considered as a locally advanced disease. Radiation has a role in almost every aspect of every stage of carcinoma lung. To begin with, it has a role in definitive treatment as a part of ablative therapy, the stereotactic body radiation therapy in the early stages. In later stages, it can be used as for definitive treatment in the form of definitive radiation or definitive chemotherapy. In resectable cases, it can be used with or without chemotherapy in adjuvant setting. Whereas in advanced diseases, but early diseases which can be resected, it can be used in neoadjuvant setting. And in advanced metastatic disease, it is used in palliative setting to give palliation to the distant and the regional local mets. The indications of radiotherapy, as we have talked about, is SABR, the stereotactic ablative radiotherapy, or the stereotactic body radiotherapy. It is used in early stage medically inoperable diseases of stage 1A, 1B, 2A, 2B, which are node negative. The adjuvant radiotherapy is used as useful in early stage non-small cell lung carcinoma, which are operable, whereas the locally advanced disease warrant that is all stage 3 diseases, and the node positive early stage diseases warrant a treatment in the form of concurrent chemoradiation. And in locally advanced disease, which are T3 invasive, N0 to N1, or resectable T4 extensive disease, that is stage 3A, or superior circus disease, which is called the pan-coast tumor, or any chest wall involvement or proximal airway or mediastinum involvement, warrants radiation in a neoadjuvant setting followed by further treatment. And palliative radiotherapy is used in advanced and metastatic cases, that is stage 4 disease, in oligometastatic, diffuse metastatic, and distant metastatic setting, and as well as to provide symptomatic relief to the patient. So radiotherapy technique, first to start with, let's begin with the conventional radiation, which is now obsolete these days. Earlier, the positioning we talk about, it is supine with the arms above the head, tumor given a margin of 2 centimeter, and areas of lymphatic spread with a margin of 1 centimeter, APPA portals respecting the spinal cord tolerance, to a dose of 45 Gray in 25 fraction over 5 weeks, followed by a 15 to 20 Gray boost over 2 weeks. So parallel opposite APPA fields were being used, and primary disease given a 2 centimeter margin. The field borders in upper lobe cases were to cover the ipsilateral supraclavian fossa, and in middle and lower lobe disease, the thoracic inlet and the suprasternal notch. Inferior being 5 to 6 below the centimeters below the canine upper lobe disease, 8 to 9 centimeters below carina middle lobe disease, and vertebral origin of the diaphragm in lower lobes. Medial border being 3 to 4 centimeters across the midline of the opposite side, and a lateral margin of 2 centimeters. In cases of gross mediastinal disease, the ipsilateral and bilateral regional nodes is to be included. The disadvantages of conventional therapy is that it increased the normal tissue toxicity, as well as it didn't account for any tumor motion. The dose escalation was not possible, as well as there was no possibility of any treatment verification. So with the advent of 3D CRT and IMRT for lung cancer, now it is the minimum standard of care is an IMRT, and preferably by image guidance. So goal is to increase the dose to the gross tumor as much as possible and minimize the dose to the normal tissue. The planning CT is done in the form of a contrast enhanced CT scan of the thorax, which can be combined with a PET CT and a fusion. Following the fusion, the planning can be done. The position is supine. The field of vision of the CT scan is cricoid cartilage to L2 vertebra, and slice thickness is 1 to 3 mm depending on the planning. And the patient is immobilized with the standard immobilization devices. Treatment planning, we talk about the target and ORR as defined as per RTOG guidelines. The planning risk volume is added to the organoid at risk. The PTV is given in the order of 5 to 10 mm if the motion compensation and image guidance is being done, and in the absence of motion compensation and image guidance, a larger margin has to be given, that is about 10 to 20 mm. SBRT based treatments require a PTV margin of 3 to 6 mm. With the advent of IMRT, there has been 60% reduction in the high-grade radiation pneumonitis compared to conventional RT. The techniques being utilized for external beam therapy in carcinoma lung are 3D CRT, IMRT, the image guidance radiotherapy, and the volumetric modulated arc therapy, and the most advanced proton therapy. So as we talk about the volume, the gross tumor volume basically includes the clinically macroscopic disease as seen on imaging, and which has been delineated with the help of an intravenous contrast for identification of the primary tumor, as well as the ones located near to hilum and mediastinum. It is contraindicated in certain cases like in atelectic cases, and an oral contrast may be warranted in central or nodal diseases, and also to differentiate esophagus as an organ at risk. A short diameter of more than 1 centimeter is applied for identification of pathologically involved nodes. A PET CT in such cases has higher sensitivity and specificity, whereas the gold standard for mediastinal nodal disease is invasive staging. Clinical target volume, as we talk about, it is the volumetric expansion of the GTV to include the microscopic disease. It is 8 mm for adenocarcinoma and 6 mm for squamous cell carcinoma. It accounts for 95% of the microscopic extension of the disease. For nodal diseases, a 3 mm margin will encompass 95% of the microscopic extranodal diseases if the lymph node is less than 2 centimeters. However, in larger lymph node more than 2 centimeters, larger margins are warranted. Internal target volume expansion is of the CTV to account for the internal tumor motion. And the planning target volume is expansion of the CTV to account for the setup variability, which is roughly 9 to 13 mm for a patient immobilized with a stereotactic body frame without the use of cone beam CT, whereas with the use of cone beam CT, it can be reduced to 5 to 6 mm. So this is a pictorial representation of the GTV. Then to include the microscopic disease, we have drawn an extra CTV. Then to nullify the internal motion, we have the internal target volume, and to nullify the effect of the setup error, setup variability, we have the planning target volume. So for all the patients, bilateral lung, excluding the GTV, has been drawn as the OAR. Where the volume receiving 20 gray should be less than 30%. Esophagus, the thoracic one, V35 should be less than 30%, and cervical V45 less than 33%. The dose constraint for spinal cord is the standard D max of for less than 45 to 50 gray. And for specific patients, V30 for less than 46%, and brachial plexus V60 less than 5% are the dose constraints. Now coming to stereotactic ablative radiotherapy or the stereotactic body radiation therapy, which is the indication being node negative disease, less than 5 centimeter peripherally located tumors. It can be used as a boost technique after definitive chemoradiation in locally advanced cases. It can be used for local recurrence for re-radiation. It can be used for intrathoracic oligometastatic diseases, and also with inferior results, it has been used for central location, multiple synchronous lesions, and chest wall invasion as well. The most vital, most crucial part of the SBRT is the tumor motion management. There has been various techniques which are used. First of all, why is the need for a tumor motion? Because the tumor present in the lung can definitely move with respiration, and if the range of tumor motion is more than 5 mm, then a tumor motion management has to be done. And in SBRT, even for less than 5 mm, because we have to deliver a high ablative dose to the tumor. So the various techniques for these are motion encompassing techniques which consider the motion and do the planning accordingly. It is the 4D CT based ITV generation, which accounts for the tumor motion and do the planning CT accordingly throughout the respiratory cycle, and slow CT scan, which is 4 slices per second. Other methods are to limit the motion, which is forced shallow breathing with abdominal compression, deep inspiration breath hold, automatic breathing control, respiratory gating methods, and real-time tumor tracking. Coming to 4D CT, the 4D CT takes a CT, acquires a CT throughout the various phases of the respiratory cycle, breathing cycle, like peak exhale, mid exhale, peak inhale, mid inhale, and a fusion CT is generated and the contouring is done on the same. We have to train the patient to breathe regularly and set up the patient in the treatment position, place the markers, that is the gating tracking we'll be discussing later, acquiring the images at different phases, and then sort the images into different images and do the planning accordingly. So it determines the mean tumor position and tumor range of motion for treatment planning. The ITV has to be delineated in all the 4 breath phases, but alternatively, it can be done on the 2 extremes, that is end inhalation and end exhalation. This is a video showing a tumor movement with respiration. This is a 4D fusion 4D CT. Now a slow CT scan is the CT is operated very slowly and the couch stays in a particular position, and the time per revolution is 4 seconds. This is done by altering the helical scan gantry rotation. In such cases, the CT images are more reproducible, but there is significant blurring due to loss of resolution, and the respiratory changes requires additional margins. Combination inhale and exhale CT, where end inhalation and exhalation CT are fused, and the volumes are controlled on the both sets of images. And in this, the significant blurring is significantly reduced, but it also relies on the disadvantage being patient's ability to hold is crucial in these cases. Shallow breathing with immobilization or dampening. It uses as abdominal compression, which is the easiest way of minimizing organ motion. Abdominal compression plate along with stereotactic frames are used. It has a rigid arc and a scaled screwed for achieving reproducibility. It permits normal respiration but is not suitable for obese patients. It has a whole body frame and with the abdominal immobilization, the abdominal compression devices. This is the abdominal plate and the screw to regulate the degree of abdominal compression. And this is a CT scan showing the same. Another method is deep inspiration breath hold method. In this, the radiation is delivered only when the tumor is not moving. This is DIBH achieved by to ask the patient to breathe in a specific manner. First, he has to maintain the quiet tidal breathing, followed by deep inspiration, followed by deep expiration, and then a second deep inspiration following a breath hold. For this, the patient has to be trained, and patient with mediocre lung functions cannot perform DIBH. So to assess this, there's a active breathing coordinator developed by Electa, which is an assisting device for reproducibility of the deep breath holds based on a principle of walled spirometer operating in moderate to deep breath holds. And the patient is verbally coached to achieve steady breathing, and safety wall is controlled by the patient. We also use a nose clipping for mouth breathing, and this adds precision and repeatability to the DIBH technique. Treatments at modern DIBH with 75% of vital capacity achieve good reproducibility. The advantages of being the breathing can be suspended at a predetermined position. We can reduce the motion artifacts. The dose to the organ at risk can be decreased, as well as the potentiation of dose escalation is there. Challenges being patient training is required, and with patients with poor respiratory function are not the suitable candidates. Respiratory gating techniques is a delivery of radiation within a specific window of the patient's breathing cycle, which is called the gate. We monitor the patient's respiratory motion with the help of external or internal fiducial markers. And these, the concept is phase or amplitude based. The fiducial signal is reflective of the tumor motion. It is a surrogate marker of it. And using this, we can significantly reduce the margin. The imaging and treatment is synchronized with the patient's breathing cycle. Disadvantage is increases the time of the delivery treatment, and it requires regular imaging and increases the dose as the 4D CT is prerequisite for gating. It has a more complex quality assurance as well, and the beam regular on and off pattern goes on for this. Phase amplitude is delivering the radiation in specific either inspiratory phases or expiratory phases, whereas amplitude gating is treating in a particular point of the respiratory cycle, that is full expiration or full inspiration. So first images are transferred to the treatment planning system. The GTV is controlled on the appropriate window. The ITV is generated, and then PTV OARs are delineated and planning evaluation is done. Then the patient is re-coached before the treatment delivery, and the verification is done by using KV-CBCT. The corresponding shifts are calculated, and the gating is done through the tracking device, tracking method, and the beam is on when the PTV comes in the gating window. So commercially available respiratory gating are the variant RPM system and the exact track gating system. RPM uses an external infrared marker, and extract using those externally placed markers which detects the internally placed fiducials. Real-time tumor tracking is repositioning of the radiation beam dynamically, so which follows the tumor's changing position, and with simultaneous tracking of the internal or external surrogate. It eliminates the need for tumor motion margin, and a fiducial is put inside the tumor or within a close proximity of the tumor, say 2 centimeters. Advantages, it decreases the time to deliver the treatment. There is no beam off during the treatment. 4 steps are: we have to identify the tumor position. We have to anticipate the tumor movement and allow time for the delays in the response of the beam positioning system. Then we have to reposition the beam for the treatment and the dosimetry to adapt for the lung volume changes and the critical structure location changes during the breathing cycle. This is the infrared marker. This is the camera which detects the motion, and the treatment is done accordingly. This is the exact tracking system where the X-ray tube is placed on the bottom and the detector are on the top, and through this tracking is done. This is a real-time tumor tracking, the CyberKnife, where the white arrow, this is the linear accelerator. This is one of the X-ray tubes, and this is the flat panel which detects these X-rays, and the synchrony camera, which does the tracking. The Electra Clarity is an ultrasound-based tracking system. Calypso 4D is a body GPS transporter-based tracking. Vision RT uses surface-guided RT based tracking, and CyberKnife uses synchrony-based tracking as well. The treatment planning, as we talk about, the planning CT is performed is the contrast-enhanced CT thorax, which can be combined with a 4D CT scan, and can be combined with a PET CT scan. Axial imaging of thickness of slice thickness of 1.5 to 3 mm. It is then transferred to TPS. The GTV is controlled in lung window. CTV or ITV is the GTV plus a margin of 0 to 10 mm, and PTV is the CTV ITV plus an added margin of 3 to 10 mm. Current radiology guidelines state, in case of non-4D CT planning, PTV has to be given a margin. PTV is ITV plus a 5 mm axial plus a 10 mm longitudinal margin. Plus in 4D CT planning, PTV is equal to ITV plus a 5 mm isotropic margin. The OARs are both the lungs, esophagus, heart, central airway, brachial plexus, and the spinal cord. Inverse treatment planning is preferably used. The number of beams being 715 in conventional image-guided IMRT techniques, and up to 150 beams in the stereotactic radiotherapy with CyberKnife. Treatment planning is the treatment volume should be received, the treatment dose should be received by more than 95% of the PTV, and the high dose region, that is the hotspot, should fall within the PTV. This is the distinction of the peripheral and central zone, where the zone of the proximal bronchial tree is called a no-fly zone, where the SBRT cannot be done. This was defined by the RTOG 0236 protocol. The dose prescription is, the goal is tumor BED. This biological effective dose 10 should be more than 100 gray. Adaptive dosimetry should be done for various histology volumes and depending on the location of the tumor. And the current fractionation scheme we employ is 1 to 6 fractions for SBRT. For peripheral lung tumors, it is 25 to 34 gray single fraction, or 18 to 20 3 fractions of 18 to 20 gray, 4 fractions of 12 gray, and 5 fractions of 10 gray. For central lung tumors, that is within 2 cm of the proximal bronchial tree or abutting the mediastinal pleura, accepted scheme is 5 fractions of 10 gray each, that is 50 gray. Commonly used doses for SAPRR for peripheral small lesions at a single fraction of 25 to 34 gray. For peripheral bigger lesions, 3 fractions, total of 45 to 60 gray. In central peripheral tumors of less than 4 to 5 centimeters, 4 fractions amounting to 48-50 gray total. And for other diseases, we can alternately we can go till 50 to 55 gray with a 5 fraction regimen, or 60 to 70 gray with an 8 to 10 fraction scheme. The dose constraints being 14 gray for 1 fraction to 30 gray 6 fraction. For esophagus, it is 15.4, 27 gray, 30 gray. In 1, 3, and 4 fractions. For brachial plexus, it has been 17.5, 24 gray, and 27.2 gray for 1, 3, and 4 fractions. And for trachea and proximal bronchus, 20.2 gray, 30 gray, and 34.8 gray, 1, 3, and 4 fractions. So the RTOG 0236 trial was a phase 2 multi-center trial, which was done on medically inoperable early stage less than 5 centimeter peripheral non-small cell cancers, giving a dose of 54 gray in 3 fractions, which showed a 3-year primary tumor and involved lobe control of around 98% with an overall survival of 56% at 3 years. The RTOG 0618 was a phase 2 trial which included medically operable peripheral disease to a dose of 60 gray in 3 fractions, and the 2-year primary tumor failure rate was just 7.8%, and whereas local failure in the ipsilateral whole lobe was 19.2%. The PFS and OS at 2 years were 65.4% and 84.4%. The RTOG 0813 was done on medically inoperable centrally located early stage NSCLC to a dose of 60 gray in 5 fraction. The local control at 2 years was high, and 2 years overall survival rate was 70%. SBRT can also be used as boost for locally advanced lung cancers. It can as a tool for dose escalation. Karam et al. Showed a local control and overall survival at 1 year of 76% and 78% with SBRT following conventional chemoradiation, and FEDOC-J reported a local control of 82.9%. Recurrence and re-radiation tool can be done with recurrence and radiation can be done with SBRT. It has role in recurrent lung cancer and metachronous primary non-small cell lung cancers. Rangolds reported a median relapse-free survival of 13.8 months and median survival of 22 months. Liu et al. Reported a local control and overall survival 2 years of 42% and 74% respectively. Now coming to the management of resectable stage 3 diseases, first talking about the adjuvant artificial indications being resected early stage 1 and or selected node negative stage 2A diseases. Stage 1 or stage 2 diseases which has been surgically upstage to N2 or with positive margins, selected high risk N2 patients which are having various high risk features like extracapsular extension, multi-station nodal station involvement, inadequate lymph node sampling, dissection or refusal, or intolerance to systemic therapy. Early stage disease with positive margins, that is R1 or R2 resection. And it can be also used as consolidative treatment after new adjuvant chemoradiotherapy and surgery in resectable stage 3A disease. This CTV includes bronchiostum, the epilateral hilum, and the high-risk draining nodal stations. Dose in R0 resection cases is 45 to 50 gray, R1 resection 54 to 60 gray, and R2 resection 60 to 66 gray for gross or residual disease. In all these schemes, the 2 gray fraction size is recommended, and in case of adequate nodal clearance, a 45 to 54 gray is sufficient, whereas after complete resection with microscopic positive margins, we have to go up to a dose of 54 gray, and a boost to high risk nodal regions should be done, and also to the nodal extracapsular extension positive nodes. The MRC meta-analysis showed improved 5-year overall survival in pathological N2 patients, that is 27% with adjuvant radiation therapy, and the ANITA trial supported the findings, giving a median survival of 65.7 months and also improved overall 5-year survival by 8.6% by adjuvant radiotherapy. Neoadjuvant radiotherapy is used in the case of Pancoast tumors or in the case of chest wall involvement, proximal airway or mediastinal involvement. Also in stage 3A, which are either T3 invasive with nodal stage 0 to 1, in resectable T4 extensive disease with nodal stage 0 to 1, or resectable stage 3A with minimal N2 disease, and which can be treated with lobectomy. The dose is 45 to 54 gray at 1.8 to 2 gray per fraction. The preoperative chemoradiotherapy, as according to Southwest Oncology Group, showed a promising result in terms of 3-year survival of 26%, and the German Lung Cancer Cooperative Group phase 3 trial showed an advantage of neoadjuvant CT-RT compared to neoadjuvant chemo alone, with the mediastinal downstaging of 46% as compared to 29%, and pathological response of 60% compared to 20%. Coming to the management of unresectable stage 3 disease, the concurrent chemoradiation is the mainstay of treatment. All stage 3 diseases, that is 3A, 3B, 3C, can be treated by concurrent chemoradiation. Node positive inoperable early stage disease, T1 ABC, T2 है with N1 disease or T3 N1 disease can be treated by concurrent chemoradiation. We use involved field radiation along with elective nodal radiation, which allows dose escalation. Accelerated fractionation in such concurrent conventional radiation can improve local control and improves the survival and decreases the isolated nodal relapse. The dose being 60 to 70 gray, 2 gray per fraction to a minimum of 60 gray. Concurrent chemoradiation as studied by Furuse et al. Showed an median survival advantage of 16.5 versus 13.3% in compared to sequential arm, in a 5-year overall survival of 15.58% versus 8.9. Concurrent chemotherapy, chemoradiation is a standard approach in patient with good performance status and minimal weight loss. And 60 to 60 gray at 2 gray per fraction remains the standard dose in stage 3 non-small cell lung cancers. And there has been no benefit for dose escalation above 70 gray in stage 3 disease. Definitive radiation as established as the standard of care by RTOG 7301 as 60 gray given in 2 gray per fraction, and by Regan et al. As 63.25 gray in 25 fraction as maximally tolerable dose. Summary being, adjuvant chemoradiation is the accepted standard of care for node positives non-small cell lung cancer. In current practice, concurrent CTRT is typically recommended in adjuvant setting if gross disease was left, and variably recommended if microscopic disease was left. For patients with N2 disease prior to surgery, neoadjuvant therapy with either chemotherapy or chemoradiation is the option. And in unexpected pathological N2 disease, they should receive adjuvant chemotherapy along with post-op radiation. So this is the various dose regimens for definitive radiation with or without chemotherapy. You go to a total dose of 60 to 70 gray, 2 gray per fraction. For new adjuvant setting, we go for 45 to 54 gray. And in adjuvant setting for negative margin, 50 to 54 gray, extracapital extension and microscopic positive disease, 54 to 60 gray, and gross residual disease, 60 to 70 gray. In palliative setting, which we will be discussing in a while. So for the dose constraint for this, for the concurrent radiation, the spinal cord Dmax is less than 50 gray, lung V20 less than 35 to 40%, and heart V50 less than 25%, mean dose is less than 20%. Esophagus, mean dose less than 34%, brachial plexus, median dose less than 69 gray. So the common acute toxicities of radiation therapy are fatigue, cough, dyspnea, chest pain, pneumonitis, esophagitis, and dermatitis. And the chronic or late toxicities which occurs after 6 weeks of the therapy are persistent cough or dyspnea, radiation pneumonitis, brachial plexopathy, chest wall pain or rib fracture, radiation skin ulceration, esophageal stricture, and vasculopathy. This has to be managed accordingly. Now, coming to the last part, the palliative RT. The indications are local palliation, that is, in the case of brain mets, bone mets, adrenal mets, or contralateral lung mets. The prevention of symptoms of pain, bleeding, and obstruction, and then supravena caval obstruction. Also, it can be used in the case of isolated limited metastatic disease, and as local ablative therapy in the case of oligoprogression on systemic therapy. So coming to brain mets are conventionally being treated by whole brain radiotherapy, but in cases of a small number of mets, we can also employ stereotactic radiotherapy or SRS. The whole brain radiotherapy to a dose of 30 gray in 10 fractions at 3 gray per fraction. And for SRS, we can be used in oligometastatic disease, that is 3 to 5 mets, which are smaller than 3 mm. Sorry, 3 centimeter. For patients with a better prognosis, hippocampal sparing, WBRT is done using IMRT plus memetin to preserve the cognitive function, and the metastasis within 5 mm of hippocampus or leptomeningeal metastasis are not eligible for hippocampal sparing whole brain RT. Now coming to the SVCO, the symptoms are fullness in the head, facial swelling, and dyspnea. And the physical findings are venous distension of the neck and chest and facial edema. So it has to be managed accordingly. It is a medical emergency. The treatment should start as soon as possible. For this, the palliative RT we give to a dose of the dose of 30 to 45 gray at 3 gray per fraction. And for bony metastasis with soft tissue mass, we go to a dose of 20 to 30 gray at 3 to 4 gray per fraction. For bony solitary bone mets, we go to a dose of single fraction 8 gray to a dose of 30 gray at 3 gray per fraction. And for brain mets, it is 30 gray, 30 gray total dose at 3 gray per fraction to a total of 10 fractions whole brain RT. Thank you.
Thank you, Dr. for giving overview of role of radiotherapy in lung, especially the non-small cell lung. You have nicely told the role of radiotherapy in very early cases as well as in locally advanced and metastatic settings. Mainly the use the innovation, new technologies which are available in radiation oncology nowadays, especially the motion of the tumor, which I told just now, that they are taken care of, exact targeting of the can be done. We can have good response rates with least toxicity. And if you have seen when we have SPRT, usually whatever normal organs are there, SPRT with the cost change with the number of delivery, changes with number of fractionation. And especially in India, most of the centers don't have a ODCT. Or another thing which can for routinely can take a CT scan in deep inspiration and one in deep expiration, and do a contouring on both the slides, and then fuse them and bring the ITV as Dr. Ashar has clearly told. So this is the routine thing which can be by using the two CT scans, inspiration and deep expiration. So total movement of the lung will be taken care of, and we are treating the most of the patients of lung cancer with tumors with this with very good results. Thank you. Any questions with Ashar?
Yeah. Thank you, Dr. Ashar Iqbal Lodi. It's excellent presentation. You have nicely explained about what type of margin you have to take, 2 millimeter, 3 millimeter, or how to take portals and SBRT, where to use and how to use it. That's very nice. And it will be a good lesson for the students. They should understand the things, and we'll try to send the video to the person who wants, or we will put it in our
Yeah, we'll make a YouTube link and then we'll post in a
very
group.
nice presentation. Thank you, Dr. Ashar.
Thank you, sir. Thank you.
And
Thank you,
now
sir.
this thing group is open for any discussions,
Yes,
any question answers. Yes, clarinet people, do you have
Yes,
any
ma'am.
questions from the audience?
Yes, ma'am. Let me check.
Please.
No, ma'am. We have not received any question yet.
Dr. Bhandari is a good team.
Ashar explained the things very clearly, such that no question should arise. He has taken each and every
Now,
complication
okay, yeah.
and advanced.
There are no questions.
How to treat, how to
Now,
what are structures and all.
Share your experiences in non-small cell cancer, like your experiences with the ordinary external beam and IGRT.
Earlier, we used to have similar type of treatment. He has already mentioned about it. With the cobalt, we used to treat earlier, and depending upon the stage, so the complication rate was a little bit high. But we have limited experience regarding LINAC, and we'll see. Although the survival has improved, but still we are waiting to get very good result with that. Because 27%, 37% survival at 5 years.
Hardly anything.
Not a good survival in spite of everything. And for squamous cell carcinoma, it's giving very good results. chemoradiation, it's giving very nice result. And people are still surviving. They are crossing 5 to 10 years rather than going for that.
No, non-small cell, yeah, small cell.
Squamous cell carcinoma, non-small cell.
That's a non
Small cell is quite,
NSCLC.
yeah. So it's very nice. Thank you, doctor.
Now we have a video before you end up.
Achha.
Yes,
Let us-
Shreya.
Yes, ma'am.
Shreya. Yes.
Yes, ma'am. I'm just playing the video.
Just play the video. Is just a
Mr. Bhandari,
model.
very good team. At friends.
Yeah,
Thank
I just
you.
want this video for
Huh.
the general public. Like people should know what we are talking of. Radiotherapy. Like even I didn't know what is
We'll talk
radiotherapy.
Should I play
We
now,
just
ma'am?
see. Yeah, you play.
Okay, ma'am. I'm playing.
Yes, yes. At least let us see in picture.
To have somebody tell me that you have stage 3 lung cancer. You think you're going to die.
Anytime you have to go through a health crisis like this, I think it's not.
I'm not looking forward to any of it. I just know I have to do it.
The recommendation was that I go through radiation. So we are beginning the first stages of the radiation.
Radiation therapy plays a very important role in terms of cancer care overall. It's one of the 3 main approaches to treatment, the other 2 being surgery and medical oncology using different systemic drugs like chemotherapy. Radiation is a non-invasive treatment. Radiation treatments are given on a daily basis with external equipment that basically passes the radiation through you. It's like a high-energy X-ray. It's something that you don't feel. When the radiation hits the cancer cells, it causes damage that it can't repair, and then they either die or basically do not grow back, and that's essentially how the radiation works. Lung cancer is very common. It's also the most common cause of cancer death. That said, it's become increasingly something that we can treat and find ways to cure.
This will be good for us to check our contours on.
In general, the higher the stage in lung cancer, the greater the treatment necessary for the patient. So early stage lung cancer is treated with either surgery or sometimes radiation alone, and many times that's all the patient needs. But when you get to stage 3 lung cancer, patients usually need a combination of radiation with chemotherapy, and sometimes surgery is also added. Lung cancer is usually found in stage 3 or 4, and only a small minority are actually found in stage 1 or 2.
They told me a lot today, but you know something? I really don't understand everything yet.
Everything going as expected?
I think so.
Yeah.
When you first come to the Radiation Oncology Center, it's very helpful to bring somebody with you. Another set of ears to hear the information is always very valuable for you. So it's very important that you ask questions repeatedly throughout your entire care to make sure that you're well informed and can make the best decision for yourself.
And what area of the body are we treating? All right.
When we decide to go ahead with treatment, we go ahead to what is called a simulation, which is the planning process for radiation treatment.
The simulation is the first step in the treatment process. It is where we determine the treatment position. We take imaging of the treatment area and also give the tattoo the markings for the daily treatments.
And then we're going to help you lie down. All right?
Patients coming in for simulation for lung cancer treatments will expect to be laying on their back in a comfortable position with their arms above by their head. And also we will be making any immobilization devices specific to the patient. The immobilization device helps with positioning and reproducibility of their treatments.
How's that feel on the top of your head, Jim? Good?
Patients will receive tattoos as their markings for their daily treatments.
All done.
It helps them align for their treatment. These tiny markings they're giving on their sides and also in the center of their chest.
That's the most inferior right there? Yeah. Okay.
Once the patient is in position, we will do a CT scan to take images of the treatment area. So the physicians and the dosimetrists can use those images to make the treatment plan, to determine the treatment fields and the treatment angles and dosing.
We are going to treat right across the suture line.
A medical dosimetrist is a professional that works with us as part of a multidisciplinary team to help ensure that the radiation dose delivery is in the safest way possible, to cover what we want to for treating the cancer, and to limit the risk of any side effects for normal parts of the body.
When we do the treatment planning, we look at the patient's tumor in a three-dimensional fashion. At the time of simulation, we can also do a special scan which incorporates the patient's breathing into the planning process. And by doing so, we can actually see how the tumor moves as the patient inhales and exhales. And we really can target and design a treatment that is within millimeters of the tumor.
When a patient comes in for their daily radiation treatment, their radiation therapy team will do a double check, make sure that it's the right patient, the right treatment, and then they're going to be put into the same position as their simulation, which is a reproducible, comfortable position that was established on their first day.
You feel like you're in there good? Oh, yeah.
After that, the therapist will set them up on the machine with their custom immobilization device, which was made for them during simulation.
Patients will be uncovered from the waist up wearing a gown, and we are always mindful of their privacy, so we will uncover as needed. Patients will be asked to just breathe comfortably and not hold their breath.
The patient can expect the machine to rotate around them. They'll hear some buzzing and clicking noise. Nothing will ever touch them, and they won't feel a thing. The actual treatment time is brief.
In general, the most common short-term side effects from a lung radiation treatment is fatigue, some skin irritation, inflammation of the esophagus, which leads to a patient feeling some discomfort when swallowing.
You're all set. You did well. Thank you.
The most common long-term side effects from radiation therapy are the changes that take place to the normal lung that surround the tumor. So some patients feel some short-term worsening shortness of breath. For some patients, it may be permanent. Because there are potential long-term side effects from radiation treatment that do not display themselves until months afterwards, patients should maintain a long-term relationship with their radiation oncologist even after their treatment is over.
When I meet with patients, one of the important things that I ask about is if they're still smoking. A lot of people do feel that if they've got lung cancer, why not continue? But that's not the case. If you stop, it will lessen the side effects that you may get with treatment and also improve the chance of survival.
I started radiation down here 5 days a week, and I go for chemotherapy once every 3 weeks. Actually, I'm doing fine. I don't feel any different now than I felt before. It actually hasn't slowed me down.
I think so. Now you can stop. Clarinet.
So this is the video just for the doctors who are not oncologists.
Yes.
Because most of the people, they are in the, most of the doctors, they are non-oncologists also. For technologists, what we are going to do, so, and what is happening to the patient. So we have to explain to the patient how he is going to get the treatment. And there is nothing to worry, nothing to feel afraid of for the big machines around roaming around. So this is for us also, as well as for the other
Patient awareness.
Yeah. So this is we have taken from the Astro videos, just for the teaching purpose. Yeah,
Yes.
Dr. Deep.
And so now, can I conclude, Dr. Virendra Bhandari?
Yeah,
Dr.
definitely,
Bhandari?
yes.
So a lot many thanks
Yes,
to you
yes.
for proposing this topic and helping all your team members to be there with you and helping us conduct this webinar so well. And thank you, Dr. Chaturvedi. Thank you, ClearNet, for your technical support, seamless support without any obstacle and interruptions. Certificates and YouTube link will be given a day or two later. They've put their email ID from where you have to collect the certificates that she has told me, so that you can see and get it from the link that I'll again post in the Oncology Integrated Society. Thank you all for your cooperation. Have a good
Bhandari
night.
and team, thank you.
And goodbye.
Thank you.
all.
Thank you.
Thank
so
you.
much. Thank you.
We'll meet in Bombay.
Yo,
हाँ
you're going
बॉम्बे
to
में तो
Bombay?
मिलना है
Yeah.
मिलेंगे फिर से
हाँ.
Okay, thank you. Good night.
Bye.
Thank you so much, everyone, for giving us the opportunity to host the session. And we hope to have you again on our platform very soon. Thank you so much.
Bye.
Good night.
Okay, good night.